Hello, I'm Jeanmarie, and today's presentation is about the difference between a coder and an auditor. I've read that it is largely medical necessity, but today we will go over the history of audit and coding as well as real-life examples that show it is much more than that. In fact, we're going to go over my real-life examples because I have a background in both audit and coding, but it's not necessarily just healthcare. Today we will be discussing the fundamentals and differences between coder, auditor, the roles, responsibilities, salaries, and duties that come with those roles. In 1988, the AAPC was created to credential and support physician coders. There's about 175,000 members worldwide with newly minted medical coding and auditing professionals each year. Does our story start there? No, it does not. Have you ever heard of how police officers and nurses make great couples? Well, my parents are a very good example of that. This is me as a little kid, and I like to say when I was small, my mom forever wanted me to go into medicine. She kept telling me it would be so nice for me to be in healthcare. She has a true passion for helping people. I always said the body is gross. I thought everything involving medicine was disgusting. So, given my option in high school, I said I'll take earth science instead of biology or chemistry. I didn't want to pith a frog. I didn't want to do any of that. So why are we here today? 30 years later, I run a healthcare company and have my CPC, which is shocking. How did I even get that? I came to this company 9 years ago with a strong background in IT and finance, both coding and auditing, but as I said, not the medical kind. A little bit about my company. We are an audit and an advisory firm located in Orlando, Florida. We are 100% woman-owned and have been around for just under 20 years. What is audit and advisory? We look at medical records and perform the work around looking at that. So that's a very simplistic way of thinking about audit. I love interns of all ages. This is one of my older interns going through medical records before the auditors get them. So we have a process where we have to intake medical records. We sort and scan them, and then the auditors review them. This is yoga auditing, which we do at conferences. It's a way for us to blend mindfulness with auditing, and it's pretty fun. So this is a bunch of different auditors and coders performing yoga in a training. Back in August of 2003, I had my first day at Rollins College in Orlando where I was super excited to be a computer science major. I didn't know what computer science really was, but I knew that my high school guidance counselor's son made a lot of money and he did computer science, so I had to do that too. What did I think computer science was? I thought it was the fun of clip art. So I was very familiar with using clip art in Microsoft Word. I loved it and I expected that's what it would be. Instead, my very first day, I had Intro to Computer Science and I saw my first set of code. It was C++. This actually, I believe, is Java. And I didn't understand this at all, but a lot of times people go into one career thinking that it's something and then it ends up being something else. Now, reflecting back, I thought that my major had to do with graphic design, but really it was about coding. And I'm glad that I didn't go into graphic design because I really don't have an eye for that. As per this entire presentation, I put it together myself, you can see. Who is this lady? Is it my grandmother? Is it the founder of the coding organization I just mentioned? No. Actually, coding all started with this woman. She is the first computer programmer, and her name is Ada Lovelace. The first programming language was created in 1883, and she, Miss Lovelace, worked with Charles Babbage on his very early mechanical computer, the analytical engine. Computer coding is the language used to develop apps, websites, software. Without it, we'd have none of the popular technology we rely on for our daily lives. We wouldn't have our cell phones, we wouldn't have Facebook. Coding allows for people to give computers and machines a set of instructions on which actions to perform. It's how humans communicate with machines. To codify, so we often hear the term codify. What is that? It's to arrange information in a logical order that allows others to follow. So in other words, it's to classify, catalog, order, organize, or group. Medical codes are used to describe diagnosis and treatment, determine costs and reimbursement, and relate one disease or drug to another. The medical coding system originated in England during the 17th century. Statistical data was collected and organized into numerous numeric codes. The codes were then used to estimate the most recurrent cases of death. Centuries later, the World Health Organization began using the list to aid in mortality rate tracking and international disease epidemics and overall trending. This list was extended further and renamed as the International Classification of Disease, which is ICD. We're very familiar with ICD-10. It's in its 10th edition. Back in 1977, ICD codes expanded to include clinical diagnosis such as illnesses and injuries, not just causes of death. Once the ICD system included the new additions, there was a way to catalog the medical records and make medical care more streamlined and offer additional insights. The HCPCS coding system was developed in '83 by CMS to provide a standardized coding system for healthcare, both services and supplies. The HCPCS system is based on the AMA CPT codes. HCPCS became necessary for all government, Medicare, and Medicaid and commercial payers to process claims consistently. CPT codes were developed a little bit further back, 1966, by the AMA as a way to document medical treatment, although the original intent of CPT codes was not for payment of insurance claims, but rather to simplify the process for doctors to document in medical records the procedures that were performed. Now we know that CPT codes evolved into a way absolutely for payment. So it's really used universally for federal government, different kinds of payers for the reimbursement of insurance claims. According to bestcolleges.com, you don't need a bachelor's degree to become a medical coder and break into this growing industry. There are a couple of resources out there that tell us 29,000 new jobs of a medical coder will be added in the next decade. The Bureau of Labor Statistics, BLS, projects that employment in medical records and health information will increase by 8% from 2019 to 2029. We're already seeing a large uptick in this. According to the AAPC, medical coding is the transformation of healthcare diagnosis, procedure, medical services, and equipment into universal medical alphanumeric codes. Medical professionals help ensure codes are applied correctly during the billing process. This includes abstracting the information from documentation, assigning the appropriate codes, and creating a claim to be paid by insurance carriers. I found this infographic on the AAPC website, and it is a little bit longer at the bottom. We see this infographic on the right side because it's small to tell you the part that matters most to this medical coder conversation. When a patient visits a doctor or a provider, the provider will document the diagnosis and the treatments. Then the medical coder reviews each note and translates the documentation into medical codes. The medical biller makes sure the necessary information is included and submits the claim to the payer to receive payment. So all of that is a bunch of formal what medical coder is. If we want to think about a basic real life example, what is a coder? This is escarole. It's a leafy lettuce-like, but a little bit more on your tongue. People say that it's bitter. I don't find it bitter. It is used in Italian wedding soup. So if you've ever heard of scudol soup, escarole soup, Italians like to call it scudol. If you're a fan of The Sopranos, you know that scudol means money. Simply put, medical coding is the process of translating information from medical records and medical information into codes for the purpose of documenting the records and informing accurate medical billing. So it really, really drives the schedule. Speaking of schedule, let's talk about leading audit firms. The Big Four, the very large profitable audit firms. You might know them from two specific recent examples. We could go back to Enron days where we would know of Arthur Andersen when it was the Big Eight, Big Ten, but we're going to keep it current to Big Four. Theranos, shown on the left, is Elizabeth Holmes, my absolute favorite healthcare fraud story right now. If you're not familiar, please stop this recording and go directly to all the podcasts, documentaries, and even the updated articles daily. I really love Bad Blood, and that's a wonderful podcast, a book. Go out and read whatever you can because it's really, really good. One of the key issues to the case with Elizabeth Holmes is that she and her company, Theranos, raised $700 million from mostly wealthy investors without ever having to provide audited financial statements. Typically, the audited financial statements of a company that size would be audited by one of the Big Four accounting firms. And what that does is allow for the investors to have comfort in an independent public accounting firm performing a review of the financials to say that it made sense and that it was correct. That didn't happen, and the large fraud was really enormous. On the right, we see the partners from PwC, PricewaterhouseCoopers. That is not Matt Damon. They were holding briefcases with the winners of the Oscars back in 2017. And PwC took the responsibility and apologized for the error that led to the mistaken announcement of La La Land as Best Picture for the Academy Award that year instead of the actual winner, Moonlight. PwC has been a long-time overseer of the Oscar voting process and said the Best Picture presenters Warren Beatty and Faye Dunaway had mistakenly been given the envelope with the wrong category. According to the Wall Street Journal, PwC has two sets of envelopes at the ceremony with the winners' names, and the presenters were given the duplicate envelope for Best Actress, which already had Emma Stone for La La Land, instead of Best Picture. I go into this long, laborious story because this helps you see what an auditor's job really is. So how many hours went into tallying and collecting the votes for the final punchline to be ruined. So that's very welcome to the world of audit. And if you've been auditing for a while, you know exactly what I mean. Fast forward 8 years after my computer coding days, I became an auditor for KPMG. So to the right, we see the Big Four, PwC, Deloitte, EY, and KPMG. What does this mean in my line of work, which still isn't totally healthcare, but I started getting there? As the financial statements get audited, so too do the IT applications and surrounding operations from a technology perspective to support the strength of the financial statements. For instance, I had several hospital clients where I perform IT audit. I would fly to different cities each week and audit their IT security controls and test the operation and effectiveness to report to the client's management. So for example, I would take someone with badge access to different rooms and I would say, come over here, let's see if you could get into the data center. And I would make sure that only people on a particular list who should have access to the data center did, and that people who shouldn't have access couldn't. Now, did I test every single person for the data center? No, I made a select sample, which I felt was representative, and it was random, and I was able to say that I had confidence over that IT control. Sure, flying everywhere and having delicious meals seems very glamorous. Working for Big Four seems extraordinarily exciting, right? Well, not really. Big Four is known for burn and churn. There's a great deal of the workforce that is recent graduates, and typical weeks are 60 to 80 hours. During busy season, it's even more. That is the inside track, but it's hard work, crazy hours. You get to work with the best people in the industry and some of the best clients. Audit is known for integrity, fair presentation, due professional care, independence, confidentiality, evidence-based approach, risk-based approach. Best practices include preparing, setting the scope, using a representative sample, evaluating controls, communicating constantly, providing proper documentation, keeping up with training. And finally, the basic principles of auditing are confidentiality, integrity, objectivity, and independence. Other important items are skills and competency, work performed by others. So you have internal, external audit, work performed by others is an important one. Documentation, planning, audit evidence, accounting system and internal controls, and audit reporting. According to O'Reilly, the history of auditing has been a worldwide profession for centuries. During the early 1700s, the concept of sampling was introduced. Sampling is where auditors select a small subset that could be applied to the whole sample when it is not economically viable to examine all the transactions that have taken place. Historically, auditing was concerned with accounting for government activities and reviewing the work done by tax collectors. In the early years of auditing, the keeping and maintaining of accounting records was done primarily to detect fraudulent activities. The Industrial Revolution in the mid-1700s to the mid-1800s was responsible for the increased demand in auditors because the period saw an increase in responsibility being passed from owners to managers. This led to an increased requirement for auditors who were independent of management. According to the CPA Journal, audits were required by law in England as early as 1845 to protect shareholders from improper actions by promoters and directors. So that's good to know. This ties back to Theranos, one of the earliest and most widely used comprehensive, influential, and durable sources of practical guidance for U.S. auditors was Auditing Theory and Practice, which was published in 1912. Following the stock market crash of 1929 and the ensuing Great Depression, Congress passed the two acts of federal legislation that would change the world of investments and auditing forever. The Securities Act of 1933 and Securities Exchange Act of 1934 was then coming out. The momentous legislation required that all SEC registrants have their financial statements audited by independent CPAs. My mother, the nurse who you saw on our first slide, said to me, I think the difference between a coder and an auditor is something like a bookkeeper and a CPA. I said to her, that's a pretty good way of thinking about it. I can't say that I completely disagree. One is an input, the other is a reviewer. I like that. There are a number of definitions for audit in healthcare. Right, exactly. Why are we even here? We're here to hear healthcare audits. So let's get into that. Auditing is a systematic and objective assessment that is designed to evaluate and improve the effectiveness of a healthcare compliance plan. Dr. Mary Harding published a paper for medical professionals, and it is hosted on the website patient.info. Audit in healthcare is a process used by healthcare professionals to assess, evaluate, and improve care of patients in a systematic way. Audit measures current practice against a defined or desired standard. It forms part of clinical governance, which aims to safeguard a high quality of clinical care for patients. The AAPC defines medical auditing as the systematic assessment of performance within a healthcare organization. It is reassuring to note healthcare auditing plays a major role in improving the quality of care delivered to patients. We often see audits used proactively to help providers learn how to document better for better coding and billing. Notice I did not say practice medicine, and I did not mention ordering tests or treating patients. These are medical necessity items, not documentation. Healthcare audits help compliance and revenue. They do not necessarily improve care. Action after audit results help improve quality of care. So, audit results occur, the audit happens, there are results. What happens with the results is the most important part to drive care. In other words, if all of your friends tell you that you should leave the person you're in a relationship with, that's just friendly input or friendly advice. Until you leave that person, nothing happens. So the information is just received and not acted on. There could be many audits that show that documentation is not supporting what was coded or billed. And unless anything happens with those results, nothing's going to happen. So audits do not drive that. The audit results do. This is me planking at 4 a.m. at Denny's a few years ago when my team and I were developing yoga auditing, which you saw the picture of a few slides ago. This, thankfully, I know, is the final chapter on me. I went from auditing at Big Four to healthcare auditing. I went from performing IT audit for hospitals to managing healthcare auditors and audit projects for payers and providers. I arrived at this medical record auditing company close to a decade ago thinking, okay, I know audit. Audit is pretty black and white. You take one set of input, you look at it, compare it to another set, maybe against some standards, you have output, everybody goes on their happy way. I really didn't understand healthcare. I didn't know the difference of a payer versus a provider. In fact, I remember my first day of work, someone asked me, who pays you? Is it the payer or the provider? And I said, I really just don't know. All I knew was my own personal life experience, that I had insurance from my employer and that if I got sick, my insurance covered it and I didn't really have to worry about that. As I got more and more into the audit, and I really do thank my team of the early days helping me through understanding this, and I still to this day am not a solid medical auditor by any stretch of the imagination, but at least I know a little bit to be dangerous, and I certainly know really good auditors in this space. My first couple of days, as I got into it a little bit more, I said, well, if a provider is doing bad documentation or bad billing, why aren't they just thrown out of the network? That makes sense. The insurance company should just say, hey, Dr. So-and-so, you have very bad billing practices. Goodbye. That's not necessarily the way that things go. Healthcare auditing is not black and white. It depends on who's asking for the audit. It depends on what the audit is servicing and serving. So payers might want to audit providers for educational purposes only and not collect back money. While on the other hand, payers might want to do a strictly financial audit and collect any of the monies that have been overpaid or due. So it wasn't necessarily a matter of throw the provider out of the network, because with that would have a large decrease in members, and that's not something that the insurance company would want to see. But more so, how can we help educate the providers? So it was a big learning experience for me. The responsibility of the health plans and government agencies is to ensure the integrity of their program. State agencies include Medicaid Fraud Control Units, MFUCUs, State Office of Medicaid Inspector General, OMIG, and other Medicaid fraud auditing organizations. Federal agencies include HHS, which is Health and Human Services, Office of Inspector General, HHS OIG, and FBI. Health plans have special investigation units, which exist for payment and program integrity to reduce fraud, waste, and abuse, FWA. Also of note, each managed care organization, MCO, or Managed Long-Term Care (MLTC) is required to have a special investigation unit that audits providers for potential fraud, waste, and abuse. These efforts drive the audit. A complaint could be made or data could show something, but without reviewing the record, not much could be determined. Audits are usually random, but on some occasions, maybe not. They usually start from one of the following: claims analysis. So when I say audits are random, let me back up. Once something is identified, then the selection of the universe could be random. How do we get to the identification of a provider? Is that random? Not necessarily. So I just want to make that clarification that getting to the provider to audit is typically not random, and that's due to just resource constraints. So how does a provider get selected for audit? How are you the lucky one? Come on down. How is it you? How's that provider? Well, it's based on a couple of things. Claims analysis. So something in claims data stood out to an investigator or stood out to someone reviewing the claims to say, oh, there's an increase in claims over here from what the provider normally does. Or perhaps this provider is an outlier and they're billing differently than other providers of their specialty. Regular follow-up with members is another way that health plans identify potential issues. When a member states that they did not receive the services billed for, that's a red flag and usually leads to audit. Anonymous complaints received by a health plan. So for instance, if a provider is sending patients to unnecessary services, or something like an adult daycare gives all their members $20 per month to attend, that could be another red flag. And then finally, also surveillance. Investigators go out and see that too many members are going to a provider in a day. That could lead us into an impossible day situation, or that members are walking into, let's go back to the adult daycare facility example, members are walking in and leaving 5 minutes later. That could be a potential kickback. Auditors and investigators are looking for proof that the services were rendered were supported in the documentation for claims submitted and paid. The most powerful line is, if it wasn't documented, it wasn't done. This is the auditor's key line. In most scenarios, the investigators or auditors are comparing all documentation supplied to all the claims that were submitted. If the audit was initiated by a complaint, the investigators or auditors will be trying to prove that the complaint was legitimate or founded. What are the outcomes of the investigation or audits? One, which is great if you pass the audit, all records submitted match the claims that were paid. Two, there's a small audit finding, which is fine. That's like the professor you had in college that loves to use their red pen no matter what. You'll always have a half a point off or something. So yeah, I get that. Small audit finding means a small amount of money is owed to the health plan due to discrepancy between the records submitted and claims. Maybe it's a small slap on the hand and nothing is owed. It's just a move forward, don't do it again. Worse is the third option, which is corrective action plan. If corrective action plan goes into place, a lot more work needs to be done on the provider side on the move forward to make sure that they're in compliance and not making the same mistakes. If there's a large finding, a large amount of money is owed to the health plan due to a large discrepancy. And then finally, which nobody wants, is an expansion of audit or a referral to law enforcement. Those both are enough to even potentially close a practice. So expanding the audit, if a provider goes from post-pay to prepay, then every single record must be audited before they could get paid, and that often adds days to payment and a lot of work to get the records into the payer. A referral to law enforcement is not good, because then that could lead to a removal of license. It could mean jail. It could mean a lot of different things, because law enforcement goes for looking at fraud, and they do have the ability to get access to everything. A removal from the health plan network, that's never a great thing either. So there's a lot of bad things that can come out of a bad audit. The other side of audit is from a provider perspective. Hospital, clinics, large practices, they often have audits set in place. Smaller practices are sometimes not fully mature in this area, but either way, it is very important for providers to be proactive. The maturity of providers, it really depends on their own beliefs sometimes. So we've seen providers say, "Oh, I'm too small. I'm a mom and pop. I don't need audits." Everyone needs audits. If a provider says, "Well, I've never been investigated before, I've never been audited, I'm fine," this isn't true. Failing to plan is planning to fail. We share with providers all the time that it is important to prepare and have a compliance plan, or officer even, to take record keeping requirements seriously. We always say a penny wise, dollar foolish, because legal bills and criminal or civil exposure are far more costly than paying for an audit. Having done something a particular way and not having been audited before doesn't mean it's correct. Again, it just means that there has not been an audit before. So we always tell providers, stay in the driver's seat and stay in front of the issues proactively. If a provider is not prepared for the audit, so for instance, if medical records are not kept up to date, if they're not imaged properly, if there is not a really good way of keeping them, I hope that they're electronic, but if there's not a good way of keeping the paper ones organized, when the audit comes around, it could be very, very costly and time consuming to get the records in place. Auditors have power beyond reviewing medical charts. Internal auditors can help with compliance and proactive measures. Externally, auditors could also help with compliance, but even financial. Auditors have the ability to determine the approach and provide a direct bottom line impact. So the approach of the audit, if you're an internal audit, you might be able to say, "Hey, provider, we should do this type of proactive audit. We should do this kind of education." We see auditors drive that all the time. Auditors' work can reduce errors and the cost of healthcare, as well as fraud, waste, and abuse. Most of all, they can educate and help correct on the move forward. The roles and responsibilities of auditors compared to coders is clear. Both jobs require an eye for detail. Auditing requires more experience. I have hired many great auditors who only have one certification, and I have hired and fired right away many auditors that have 4, 5, 6 certifications. Certifications does not dictate how well someone can do the audit. Level of education does not dictate how well someone can do the audit. It's a matter of responsibility. I have never hired an auditor who has not been a coder before, so typically it would be coder and then auditor, usually coder for 3 to 5 years, then an auditor. There's a big issue of chicken and egg though, so if you want to get into audit and you haven't audited before, how do you get into audit? So that's one of the difficult areas in this space between truly like brass tacks of what audit means. So if you're looking for experience, one thing that you can do is obviously network as much as possible. You can apprentice somewhere where you're working under senior auditors. They could QA your work for you. Typically what we'll see is an auditor gets hired, and then 100% of their work is checked for quality assurance, so QA. As they continue on in their audit role, their QA will move from 100% down to 75%, 50%, 10% on the move forward. It's just a matter of proving the quality as you're working in there. Average salaries, coder about 43,000, whereas auditor average 75,000. I've seen auditors start at 45,000, 50,000 a year, while top 10% makes 100 100,000, 120,000. That could happen. It's based on which who you're working for. It's based on also the area that you're in. So insurance and technology companies pay the most, and geographic locations also drive higher salaries. For instance, auditors in the Northeast are making more than someone in, say, Nebraska. California is another also pretty wealthy area for auditors. Obviously you have cost of living and so forth, but here's some bigger salaries out that way. One thing to note, I receive messages from companies like this all the time on LinkedIn, my email. There's quite a bit of outsourcing done in both coding and auditing. More in coding than auditing, but there is a good amount of remote workforce offshore performing audits and reviews. There's always a conversation of cost versus quality. So if you're paying per hour, for instance, for a coder or an auditor, usually coders are paid per piece when you go to the external firms. Auditors are paid per hour, maybe per audit. When you outsource to offshore resources, sometimes you might see an uptick in hours. Lower rate uptick in hours ends up being the same amount. You might see a little bit of a decrease in quality. It all really depends. It depends on your experience. I've had great experiences, and then I've had some poor experiences. It really doesn't matter who you go with, just as long as you're comparing the quality to make sure it's in line with what you want. Many believe that outsourcing medical coding keeps billing flowing effectively, getting bills out quicker, getting payments back sooner with less expense. I've included a good article in our resources tab to address the good, bad, and ugly of offshoring. AHIMA is a wonderful resource where healthcare leaders across the industry collaborate, and the resource that I've included is from AHIMA. Medical necessity is a big debate in my house. I've been taught that medical necessity is peer-to-peer review. The patient was sent for an MRI. The MRI wasn't medically necessary, or was there any kind of necessity driving it? Who can make that argument? An auditor could say that the documentation didn't support the MRI being ordered, but can an auditor challenge the provider for ordering the MRI as part of the plan of care or treatment? To prevent improper payments and protect the Medicare Trust Fund, Medicare contractors operate the Medical Review Program. Medical records involve the collection and clinical review of medical records. Medical reviews involve all of that. So we have medical records coming in, we have clinical documentation reviewed. So these reviews are looking at information to ensure payment is made for the services that meet the Medicare coverage, coding, billing, medical necessity requirements. According to healthcare.gov, medically necessary services are defined as healthcare services or supplies that are needed to diagnose or treat an illness, injury, condition, disease, or symptoms, and that meet accepted standards of medicine. Further, CMS defines medically necessary services or supplies if they are proper and needed for the diagnosis of or treatment of the medical condition, are provided for the diagnosis, direct care, and treatment of the medical condition, or meet the standards of good medical practice in the local area, that are not mainly for the convenience of the member or the member's doctor. According to CMS, some services not considered medically necessary may include hospital services that exceed the Medicare length of stay limitations, evaluation and management services that exceed those considered medically reasonable and necessary. Maybe, like, for instance, I go in with a hangnail, I come out with multiple x-rays, MRIs, and stitching, right? Like something like that. A full list is included with the resources at the end. Simply put, medical decision-making, MDM, and medical necessity are often used interchangeably. There is a piece to it which includes the provider's part, which is based on their training and experience. The other piece is what will be covered for payment by insurer. Medical necessity addresses the point of the healthcare services and supplies that they must be necessary and appropriate for the evaluation and management of a disease, condition, illness, or injury. On the other hand, the care must be considered reasonable compared to current medical standards of care. There's so much gray when it comes to the medical necessity for performing a certain level of history for a particular presenting problem. If a medical provider documents a detailed history and a detailed exam, who can actually challenge if it was needed? An auditor, not really. Perhaps only a group of peer-to-peers. I will tell you that with all of the experience that we have with audits in the payer space, when medical necessity is challenged, we have always seen a request for it to be peer-to-peer or some other type of clinician, whether it's a nurse or some other type of provider, ARNP, a PA, to perform the review so that it could hold up for the long term, whether it goes to court or whatever. So it's whoever determines what the medical necessity review required is who is asking for the audit. So it's the person driving the audit or the group driving the audit. My payer clients have always asked for it to be, again, a nurse or a doctor or another provider. CMS states medical record review for the purposes of determining medical necessity requires a licensed medical professional to use clinical review judgment to evaluate medical record documentation. Recovery audit contractors, we know them as RACs, leverage certified coders just like payers for coding documentation, and licensed medical professionals will perform the medical record reviews for the purposes of determining medical necessity using their clinical review judgment to evaluate medical record documentation. At the end of the day, documentation is compared to payer policy and regulations, but not medical necessity criteria for performing a certain level of history and exam for a given chief complaint. Coders and auditors use their best judgment to determine how severe a patient's presenting problem is, but this is only based on the provider's documentation. If there is any question, the coder or auditor must ask the provider. Here's a list of resources that we went over that were cited either in individual slides or additional reading homework. Included Theranos podcast, The Dropout, the documentary Inventor Out for Blood. Excellent. It was the inventor. We have the PwC Oscars. We have the history of audits, CPA history of audit, coding auditing, salaries, and the outsourcing piece that we discussed, as well as some really good articles on medically necessary and the medical necessity, so versus MDM. So I do invite you to go check those out. Final recap: coding is input, auditing is checking that the work has been done before. So checking that it actually has been done as it is said to have been done. So coding is input, auditing is the checking of that input. Now that you know too much about me, I want you to feel free to reach out to me anytime, and if I can help at all, please let me know. Here's my contact information. Thank you.